what I mean by that is CCGs, commission support units, acute trusts, mental health trusts and community trusts, whether they're independent social enterprises or whether they're within acute or mental health trusts. And what we try to do is identify what good looks like in the NHS. We're a membership subscription service, and this means that we're not funded nationally by any other sources. So members sign up to become members, and they then can opt in to take part in any of our benchmarking exercises. The topics we cover are member driven, so we survey our members each year, ask them what do they want to look at, what's a hot topic at the moment, what are the demands in the NHS, and where do they want to potentially find cost efficiencies or service improvement opportunities.
Brilliant. And so you work predominantly, who is your membership made up of?
We've roughly got 100% mental health trusts signed up to the network within England. We've got the
100%. By that you mean
all
100%
mental health trust providers
are involved as members.
They're all members of the network. They pay their annual subscription fee. They take part in all our mental health benchmarking projects. We also cover Wales, Scotland and Northern Ireland as well, and we have 100% coverage in Northern Ireland
so
and
bigger
Wales.
than England.
It is, yeah. And then we also have probably around sort of 80% of the acute trusts, around 70% of the community providers that are independent, and then obviously those that are integrated with acute and mental health trusts.
And so what kind of initiatives, if we talk about mental health in the first instance, what kind of initiatives are they involved in with you? Why are they signed up as members?
Well, basically there's not a great deal of nationally available data out there on mental health. So mental health trusts do struggle to, obviously internally they know how they're performing, but to compare themselves to other trusts, there is not a lot of national available information out there already. So obviously there's an availability in the market to provide some benchmarking services for them. So we look at mental health patient and community services. We also look at CAM services, which is the child and adolescent mental health services. We look at older people and working age adults. And we also look at learning disabilities as well. So we like to think that we do cover the full spectrum of mental health services within the NHS at the moment.
And talk to me in terms of Lord Carter's productivity review. This is Lord Carter of Coles, who was asked to do a productivity review by the Department of Health, looking at variations and making the acute sector more efficient. I understand that you're doing some work around that.
Yeah, we've got two other projects that we work with, which is our corporate functions benchmarking project that looks at about 14 different back office functions such as your financial, payroll, HR. We also have a project on acute pharmacy as well. That project actually allows mental health trusts and community trusts to take part in it as well. And because we do those two projects, we were approached by Lord Carter to help inform them on their data set. So particularly with the pharmacy project, that informed the last report that we published. We're going to be doing the same alongside the corporate functions project, and obviously if there's any other areas where we can help them, identify cost efficiencies, opportunities for service improvement, then we're happy to do so.
Brilliant. And that falls in line with all the trusts who've now got to develop plans for their hospital pharmacy transformation plans. So we look forward to hearing more about that from you. And finally, as an organisation, what's your strategic objectives over the next 12 months? Who are you looking to gain more of as members? In which particular topic areas? What's your key strategic priorities?
Ideally, we would like 100% of NHS commissions and providers as members of the network. Obviously, the more organisations we have as members, the more robust our data and analytics is that we produce. So like I said, we've already got 100% of the mental health trusts in England. If we can get the 100% of the acute trusts and the community providers on board, then obviously the data sets that we produce, will be sound. They'll be able to see a true reflection of how they compare to the other organisations within the NHS, and be able to identify, opportunities to improve their services, identify what good looks like. We do work with organisations in addition to the benchmarking. We found that organisations do something quite innovative, that they've identified that they had a problem area, they've turned that around by implementing a new service, or they've put a business case together to get extra resource, and we've used our evidence to support that business case. And then obviously we then took part in benchmarking again the following year to check what they've implemented, has been successful, they've got that evidence to prove it, then what we do is we ask them to develop a case study, we share that with the membership, so hopefully, it isn't just something that's happening in one corner of the country, it can be implemented across the whole of the NHS curriculum, and then therefore you've not got this issue of people maybe having one level of service in one area and different levels of service elsewhere.
I think benchmarking this way is truly about shared learning. So continue to follow us with the hashtag NHS Learn. Thank you very much. Thank you.
I work for the Chief Scientific Officer's team at NHS England, and our role is to help deliver genomics and personalised medicine for the NHS as a whole. So we're trying to transform the way that the NHS works and a complete way of thinking about treatment and care on its head.
We're really passionate about working with scientists, with academia, with industry, with all our partners to look at the best way to use innovative diagnostics, devices, genetic discoveries to best treat patients.
Medicine's a bit like getting a made-to-measure suit rather than just something straight off the peg. If we can better tailor the knowledge we have about an individual, we can understand how they are, the particular nature of their body and physiology, we can better tailor the treatments to them, and they get a better outcome at the long run, which is a great gain for the NHS. It should save the NHS money by getting the right treatment at the right time. It should also avoid bad side effects from drugs that don't work for people.
We've also seen so many advances already, haven't we, in cancer treatment, in the ability to test for a gene, cancer, and then give patients the best treatment first time. So we get better outcomes, we save money, but it's also less side effects in some cases for patients.
Yeah, and there are lots of the common diseases. I mean, cancer is a big area for personalisation. Diabetes is another area for personalisation, and kind of going forwards, it'll be looking at areas like mental health, where we know there's a tremendous variation from one person to another in terms about whether the drugs work or don't, and we're still not quite sure why. So it's a great learning exercise. But I think personalised medicine is going to touch everybody's lives in the NHS. It's not just for specialist teams. It's for everybody right through to the front line of primary care. Kind of in the same way that knowing about microbiology and knowing that bacteria matter in hospitals and healthcare settings, from whether you're the chief executive or the cleaner. Genomics and personalised medicine will touch everybody's life in that way. So it's important that everybody has at least some understanding about the area and how they might use it in their kind of sphere of work.
It's already benefiting patients in some treatment areas. For example, cancer, we've seen huge advances.
Outside of cancer?
I'm really good example. We're seeing great advances in areas like children with rare disease. So you have a child with rare disease, you go through years and years of tests and diagnostics, and we've had children from some parts of the country who they've eventually got a diagnosis and said, just change this child's diet and suddenly their epilepsy will get a lot better. We've had children with, young people with diabetes who've been on insulin injections for years when actually they should have been on tablets, or even somewhere they found they should be on nothing at all. And in terms of having an NHS that lasts with all the financial pressures, there's nothing much cheaper than nothing at all.
We've got the ability to also screen for familial hypercholesterolemia now, for increased levels of cholesterol, so that we can help patients make better decisions at an earlier time in their treatment as to how they want to lower their cholesterol.
Yeah, so you give people, people have got kind of genetic high cholesterol. You can give them drugs to stop it, and that stops them from having heart attacks before they're 50. And a saving to the system, but a huge kind of transformation of people's lives, and the human cost mustn't be underestimated.
And the avoiding adverse drug reactions with HIV.
Yeah.
Some of our treatments now, in the past you would have had treatment, standard treatment for HIV, and you may have had a bad reaction to it. Now that we can check the gene that causes that, we can prevent that happening. And that also saves a huge amount of money. How many admissions did you say in a hospital
Oh, well, they reckon
For adverse drugs,
they
yeah.
reckon 1 in 15 hospital admissions, 1 in 15 people going through the front door of a hospital is because they've had a bad reaction to their drugs, and about 70% of those are preventable. So actually, if we can use modern diagnostics to stop those sorts of things from happening, that's a tremendous burden on patients and on the service that we can lift.
And so where does diagnostics fit into all of this picture?
Well, diagnostics essentially is the guide for all the decisions that we make within the hospital. It's our, I guess it's our signpost as to each stage of treatment that you receive. So diagnostics are critical anyway. In fact, they're related to over 80% of all decisions in hospitals. But what this does is it takes our expertise in diagnostics and it allows us to do things even better and quicker. So a lot of our techniques now, rather than being in a laboratory, can be nearer patients. So we call it point of care testing, and we can take all that technology that was once fitted into machines the size of a Volkswagen Beetle, and now a small handheld device. We can take it next to a patient's bedside, we can take it to a patient's home, and we can do on-the-spot diagnostics. We can make a decision there and then as to the best treatment and talk that through with the patient.
I think it's easy to think that personalised medicine will just be about generating really expensive drugs, and that isn't the case. As I say, sometimes for things like in diabetes, you can end up using cheaper, easier drugs to get the right patient diagnosed with the right way and put onto the right treatment. It can help the pharmaceutical industry. For example, some drugs in the development process fall by the wayside, but if you find the right group of patients for whom those drugs are effective, those things that you've invented before but never brought to market, you can pull off the shelf, you can reuse. We now can look at cancers and say, what felt like being different, like a brain cancer or a colon cancer or a lung cancer, we used to all treat differently, but you can look and say, if it's the same genetics behind them, then we can use the same drug. So we can extend the drugs we've got for one thing to something else. Again, more efficient and saving the NHS money. The foundations for personalised medicine in the NHS are the 100,000 Genomes project. So there's been a network of expert centres, the NHS Genomics Medicine Centres, set up and down the country, each of them serving about a population of 3 to 5 million. And all the hospital and health services within those regions are part of each genomic medicine centre. So this is establishing the infrastructure that will allow us to build knowledge about personalised medicine.
We both work in the Professional and Clinical Standards Department, which has a pretty wide remit. We develop professional and service standards. We carry out do commissioning guidance. We do work on healthcare data. We've recently done a large piece of work on setting standards for cosmetic surgery. We also do quality improvement projects and bespoke projects, and we do invited reviews.
So my specific role is to go out to NHS trusts on behalf of the medical director and look at surgical teams and surgeons to work out where they need to improve their healthcare and how to do that.
Okay, and my role has been largely to do with commissioning. So we have found that over the years, quite common surgical procedures, there's a huge range in variation in activity and access for patients. So certain areas you can get your tonsils taken out, and other areas you have to wait a lot longer. It's a bit more difficult to get them done. But actually there's quite a lot of evidence that at the right time for the right patient, actually these procedures are very good. And so we've been trying to work with commissioners, trying to standardise and provide data and help to sort of standards and allow people to measure their performance. That's sort of the key part of my work.
And the next 12 months?
Next 12 months,
What's going to be exciting?
we're working with NHS England and Right Care to produce really quite detailed reports for each clinical commissioning group and each acute provider, looking across all of their surgical services and comparing themselves against national average but also against matched peers, and looking at activity, costs and outcome measures across piece of work and really help providers and commissioners really get an instant view of what's happening in their area and maybe start to look at where they can make changes.
People.
I think we get contacts from a lot of different people. So yes, in terms of commissioning, we're keen to get in contact with planned care leads, people who are actually doing the commissioning of services, but also in contact with providers who are wanting to make improvements, make changes, and contact their commissioners. We also get, in our other work, we have contacts all the time from managers, from individual clinicians about guidance and best practice, and it's a work that we're doing. So we have quite a wide contact actually across surgical services.
For ourselves, because we're a medical community, we generally work with medical directors, so we get referrals from medical directors and we'd like to work and engage with them in the future. Again, heads of department, clinical directors of departments would be really helpful. You can get in contact with us and we'll go through the whole process and let you know exactly how we can help you.
And what was your relationship you were saying with Right Care?
So Right Care and
NHS Right Care?
Yeah, they're now part of NHS England, and they've the work that we did in commissioning was also initially a Right Care project in 2012. So we have been working with them. They obviously do work for commissioners at quite high programme level, looking across whole pathways, mental health, cancer pathways, and our data is only surgical, but it's much more granular, so it's looking at much more detailed level. So we're basically bringing the two pieces of work together.
Showcasing our staff engagement model that we've designed and developed in-house at Wigan and Lilley, which really focuses on improving staff's experience in working in the trust and really helping them come up with new, innovative and effective ways of working.
Fantastic. And is this a new innovation, or have you been doing it for some time?
We've been designing the model now for the last 2 to 3 years. We've seen some really good results in terms of our national staff survey results over the last 4 years.
Right. And so who in particular are you keen to have this conversation and share this learning with? Are we talking primary care or secondary care?
It's for everybody really. We're really keen to broaden our collaborative with other NHS trusts so that we can really learn from each other, and also look at areas where we can look at how we can sustain staff engagement in the future with challenges that are facing the NHS at the moment.
That's brilliant. And who would you normally converse with? Who would you normally liaise with initially? Is it the trust board who you need to be having those conversations with, or is it directorate head?
Yeah, we're happy to have conversations with anybody. We do a lot of talking with trust boards. We do lots of talking with HR directors, directors of...
I'm concerned that we don't have a 5-year forward view anymore. What we have is a 200-week forward view, and we're running out of time. My challenge to the organisations is what will happen? What are you doing now to make sure you deliver something for the 5-year forward view? Secondly is about change. Almost my entire career I've got wrong, I think, because I've done a lot of top-down change. I don't want to do top-down change anymore because I've learned that real change comes from the ground up. If you want real change, if you want change that sticks, change that lasts, ask people doing the job, what would they do differently? How can you help them do it differently? That's where you'll get change.
We do work with several of the trusts and several healthcare organisations worldwide, but here in the UK we work specifically with 5 trusts to help them implement Lean as a management method in their organisation to help them build a culture of continuous improvement for patient safety and patient experience in the healthcare systems. Yeah, we're working with 5 different trusts currently and a long engagement to help them build Lean as a management method.
Right. And why are you experts in Lean?
So about 15-16 years ago, our healthcare organisation decided to adopt the Toyota production system for lean manufacturing principles to healthcare at Virginia Mason Medical Center, and we saw great success over the years in eliminating waste from the patient experience, that a lot of patients from all over the world came to us and said, how did you do it? So in 2008, Virginia Mason established Virginia Mason Institute, and now we get to spend all of our time going worldwide and explaining how we implemented Lean as a management method.
And So give me one example of what waste looks like in the patient experience.
Sure. When a patient comes in and, for example, waits in a waiting room, that's not value-added time for the patient experience. So we look to seek ways to eliminate wait states or things that are not value-added from the patient's perspective and from the patient's happiness.
The Accelerated Access Review, and this is looking at how we ensure that the NHS is a good receptive environment at sort of various stages of the development pathway for new medicines. So for some new therapies, we may not know at the point they get their marketing authorization exactly what their real world impact will be. And rather than just have a kind of binary yes, no, nice type process, what we're doing increasingly, we've done this now with oncology agents, cancer drugs, is saying you've got up to 24 months where we will fund the use of the drugs so that we can see how patients actually benefit. Could we expand that beyond just the cancer area? Potentially we could. And then when we know the answer, the yes, no, maybe answer at the end of that period, we obviously want to ensure that there's faster diffusion of those therapies across clinical practice. None of which is to deny that there aren't very real pressures. Of course there are. But what this country needs is a strong life sciences industry with a receptive NHS. And I think there is a win-win there if we can help take cost out of the drug discovery process and, as a flip side, ensure that patients then get faster access to the best drugs. And behind what we're doing together here in Greater Manchester is, if anything, accelerating. I mean, when we were here this time last year, I described the fact that Howard and I were co-chairing the Devo-Manc Partnership Board to get this arrangement up and running for the 1st of April. We've done that. The potential to bring together £6 billion worth of health and social care funding for the 2.8 million people across GM is enormous. And there are some very tangible benefits to this. And I think ultimately this will be won or lost on the strength of the tangible benefits. So to the extent that GPs across Greater Manchester are saying, here's what the offer to the public looks like 7 days a week, to the extent that you see some of the really interesting innovation going on in places like Tameside, where we've just appointed the Chief Executive of the local authority as the Chief Executive of the CCG, where the community health services staff and the hospital staff have come together, and the Borough Council, I think, is proposing integrating the social care staff there as well, mirroring some of the work that's been going on in Salford. The fact is that Greater Manchester is a fizz of change and integration, and that logic persists, and I see no sign that it is being undermined.
Our company is around matching patient needs. So when a patient presents with some complex issues and a range of issues, actually enabling the clinicians or the coordinators to access whatever range of package of programme and services that are out there, and facilitating that matched referral into those services and providing visibility to all the stakeholders, all the clinicians that are involved, and anyone that's an interested party, to actually see where the patient is in that patient journey. So if a patient's trying to access a bedded facility and long-term care nursing home, being able to provide them access to which actual services, which homes physically meet that patient needs, and allowing them to be enabled to make a choice within that. So driving that patient choice, allowing the patient to choose where they want to go, but also where is appropriate from a clinical perspective that they should go, and then enabling them the referrals to go out to those services, and the services to pick that up and actually accept the patient in, and provide that visibility right through from point of care, point of referral, through to final transition into that service or package of services ways. But really it's around the managed service of delivering that business process improvement. These workflows, these processes exist, but they're all disjoint, they're all sort of paper-based, the telephone, there's emails involved.
Not interoperable.
And nothing's interoperable, so we provide, as we describe it, the glue between all the different providers that are out in the economy, so that the acute trusts, the GP practices and services and systems, social care systems, third sector, private sector. So whatever's commissioned in a region in a health and social care economy, allowing them all to plug into a single system that isn't their business process system, isn't like their EPR in the hospital, their medical record system. It's just the bit that at point of care they need to transition from point A to appropriate point B in a reasonable amount of time and a reasonable amount of pace, actually improving that workflow, but also enabling the better process to be embedded and to be delivered. So it gives an opportunity, and an ideal opportunity, to look at business process improvement and simplification by removing out all the duplication, all the unnecessary steps and all the unnecessary handoffs, which reduces out all the inaccuracy, all the waiting time. So so you can drive down your delayed transfer of care. You can place your patient, your clients into the appropriate services much quicker, much more appropriately at the first point of call. So when they're moving, they move to the most appropriate place.
There's continual talk in government and NHS about constant transformation and integration. Are we there yet? Or are we still very far away from joining all services, particularly around health and social care and the local government environment?
I think we're still quite some considerable distance from that. There's a lot of initiative, a lot of talk around that, but actually when you sit in the meetings, at some of which I'm privy to and we see, there's still quite different distant systems. So some of that difference in distance, is real and is recognisable and is quite normal. They're doing slightly different jobs within the whole workflow process. But what nothing really does is bring that together and bring that workflow and allow the information that's pertinent to the patient journey just to move seamlessly. What a lot of initiative seems to be about is moving the whole thing around and trying to marry and bolt together huge systems, and actually all that's necessary is just that little bit of information that's pertinent and relevant to that point of transition, that point of care. So one of the things that Strata really looks at the key information that is necessary to make that transition and to look wider and to access those range of services. And seeing that holistic whole system approach to drive out all the delays that are within that whole system wide, rather than just an element or a slice of it at one end.
Right across the patient pathway.
Absolutely right across the patient pathway, and that's really where the gains are to be had. The gains are fairly marginal and minimal if you're looking at it just from an acute setting perspective. A hospital can push patients out quicker, but in reality they're not getting anywhere much quicker. They're just going to some degree inappropriate settings. What a solution like ours enables that whole system-wide end-to-end, so from points of coordination, point of referral, to actually the patient is in the right place or the right package of services, drives better outcomes. One of the things we drive down delayed transfer of care that I mentioned, we look at between 20 and 35% reduction, quite simply, on delayed transfer of care, just by placing patients and giving clinicians and providers access to the right information, so they're not spending to a week, we hear anecdotally, a week looking for an appropriate placement. That time, this is a live system and a live service, so the coordinator in the discharge unit can actually see what is out there, record the document what information is required, send out the range of referral to the package of care. And actually see the responses coming back in real time. So when that package is built, we know now the patient is ready and safe to be discharged through that range of services or to the service, and can go home and or to the next point of care that is appropriate at the time.
So the key thing for us is really how do we help the NHS move away from this paper-intensive situation they're in today, and how can it really work with them to eliminate paper from the patient process. Yeah, so typically a patient would turn up in a hospital, and often they'll find themselves given their names and basic details 4 or 5 times before they even get seen, and really a poor experience for the patient, a waste of time, lots of administration, lots of paper, and really we're trying to help the NHS to eliminate that, move to electronic forms, for example, making sure that paper-based medical records are a thing of the past. Lots of activity in that, but how do you digitise the legacy notes, make them available for clinicians to see anytime, any place, multiple places at once, and really improving that whole patient experience, but ultimately helping the NHS eliminate cost and inefficiency.
Arden and GEM is one of the largest Christian support units in the UK. It provides services to over 60 CCGs, to NHS England, and to a number of provider trusts and other bodies, ranging from business intelligence through to finance services, through to HR, through to contracting support.
So I think I suppose it's fair to say that good at our transactional services. What we need to get into is much more of a transformational market, and we really need to be sort of a provider of choice in terms of helping our localities with STPs.
So STPs really are a big new opportunity around.
So these are the sustainable transformation plans.
Yes,
How do we get into population health management, support STPs, trusts and commercial organisations with reducing health spending?
And I think we could, again, we've got those two offerings, so I think we can get into the provider transactional outside of the business, whilst at the same time also helping that whole STP area with their population health management. I've just come from a session where we've just presented the work we've done around mental health, and over the last 5 years we've saved £12 million in mental health and monitoring. If we can just roll out that type of support for our health systems, that would be that would be successful.
Brilliant. And if we were having this conversation 12 months down the road, what will that look like? What is it that you think you definitely will have achieved? What might have been a little bit more tricky? And what might be some surprising elements, good or bad?
So what stops us really getting into the STPs is the fact that we've got to finish off the legal provider framework. So we need to go ahead and win back and maintain all the current customer base, don't we? So what we need in 12 months' time is to have maintained our current customer base, be their provider of choice through the legal provider framework, and really be helping those health systems with their STP plans.
So you manage services on behalf of how many CCGs?
60 CCGs.
Wow, gosh.
Yes, 60.
Yeah.
And also, again, we provide a lot of support to NHS England for direct commissioning. So
brilliant.
Lead on that nationally.
I think anything that we can do to share patient records between services and organisations, etc., will then lose those black spots that you can tend to happen. So you can get a patient journey from the point of an accident or an illness to right the way through to completion of actually having a resolve to the issue. And you can see the other services have the ability to see exactly what's happening along every step of that way as well. I think a good analogy would be really, if you can imagine you went out one day on your bike, you get knocked over. At that point in time, the ambulance services has no way of seeing what actually is on your clinical record. So if they go now to treat you and they have to use medication to do so, there isn't actually a great deal of information there at hand to know what your, for instance, allergies are or what actual medication you're currently on. So interactions and things like that can happen. Also, when they then get picked up and you go to A&E or go through to the hospital, although you've gone into the hospital, the way that most hospitals work is each department doesn't communicate properly with each other. So you can, for instance, if you go to hospital, you tend to find you get asked the same questions in different wards and things like that. The reason is that's right. There isn't always that communication flow between the point of entry to the point of you then leaving that hospital. So what we've actually done is, with our system, we've actually started to plug those holes. So in Cornwall, for instance, if you did have an accident and you had to go to the hospital, they can have access to your patient record from the point of you being collected through to being admitted to hospital, to having your medications reconciled to make sure there's no interactions, etc. And all that is audited and pushed further. So everything that happens within the hospital is always notified and done back to your surgery as well. So your surgery is aware of what's happening. The next step for us is to try and engage with other services such as physio, for instance, and social services.
Which is part of the GP forward view now.
That's right. So for instance, you could then come away after having an accident, and the next step would be the physio. Well, the physio would have a very small section of your medical record to see what's happened to you to date on that illness that you've got, how it's been treated, then go through and also can add to that record. So then when you go back to your GP sees everything that's happened to you from start to finish. Another key piece that's actually part of this as well is care plans. A care plan at the moment in some areas is done in a Word document, and that Word document lives within the clinical system of the GP. What happens is they'll hand that out, for instance, to the palliative care team or other areas. Well, that's great, but there's no way of that document being updated. So what's happening is you can very quickly end up with an out-of-date care plan. Also, there's no input from the actual patient or the patient's family. So one of the pieces of software we have gives the ability that it's stored centrally away from the clinician, that everybody has access to update it, change it, add new ones. and also gives you a history as well, so you can see previous medications that's been issued, things like that. So everybody will have a different view or a different rulebook, but they all have the ability to change and add extra information into that care plan.